left?
It should be green.
What does it mean? What's SQI mean?
Swan quality index.
Swan quality index. So if it's reading 4, you need to shoot an X-ray, call intensivist, figure out, what's wrong with the swan. Might be not in good position, might need to be flushed, recalibrated, whatever. You know what I mean? But there's something wrong. So to make all this work, so this tells you this will be the first thing that will drop to. That's why we have the continuous cardiac output swans. That's why it's important. This will be the first number that drops. And if this is not normal, and normal is 65 to 75, if this drops, it's one of 3 things: cardiac index, hemoglobin, sat. So those are 3 things you got to look at. What's their index? What's their hemoglobin? And what's their sat? You got to fix one of those 3 things. In cardiac index, so if the cardiac index is low, you got to look at 3 things. First of all, what's their heart rate? Are they going 180? Are they in some crazy rhythm? They can't generate one. If that's okay, preload. What determines preload? How do you determine preload? Looking in there at that box in the swan numbers. CVP and what? PA diastolic. Which one should be higher normally? PA diastolic or CVP?
Should be higher.
PA diastolic should be higher.
CVP should never be higher.
PA diastolic should always be higher than your CVP. If your CVP is higher than your PA diastolic, what do you think?
Tamponade.
Tamponade. Now, but the key to that is you got to know, you have to ask the anesthesiologist, they should be checking this out to you. What are the swan numbers when they put them in pre-op? Because normal PA pressure is 20/10, normal CVP is 2 to 8. Okay? So, but like his PA pressure, when we put the swan in, for like 50/30, and his CVP was like 20. So if you look at his numbers, his PA pressures are 35/18 and CVP at 10. What's that mean?
Dry.
He is freaking dry. So when they called me last night, he was on levo at 14. Milrinone was up. Milrinone had to get stopped. We had to thump him with volume and give him bicarb. His base deficit was 6. That's the other thing. If you got a big base deficit, your pressures aren't going to work. You'll be hypertensive. You always check that base deficit. You got to correct that. So, but he needed volume. That's why you have to know what the filling pressures are from the OR. That's the key. You have to know that. Like, that's the first thing you got to ask.
Have a paper.
I thought that was part of the checkout when they come upstairs. I thought that's what they did.
They used to.
Yeah.
Back when you were here.
Well then you guys just have a sheet when they come up. Just say what you ask them. What was the PA pressures? What was all that? Because you got to know that. What was the EF? Well, all that stuff.
Just trying to make it consistent.
Yeah, but that's all stuff you just have to know that, because otherwise, like that way, when you call me and their hypertension, their index is low, and I said, what's their filling pressures? You tell me, well, then you should also say, but they were X originally, because that's how you gauge it, right? So preload, that's volume. Afterload, contractility pretty much usually go together. Like if the SpO2 is high, they usually just, not SpO2, if the SVRs were high, they usually just need volume, they need to be warmed up, all that stuff. But bottom line is, if their heart rate's okay and you got adequate tank, contractility means you had a drug. Okay, that's what that means. So the way you got to think about these drugs is what they do to the index and what they do to the blood pressure. Because if somebody's index is low but their blood pressure is low, there's a certain drug you pick. You know what I'm saying? Like you can't. That's why you have to know what these do. So let's start with epi. What does epi do to your cardiac output? Increases. What does it do to your blood pressure?
Increases.
Dopamine. What does it do to your cardiac output? Increases a little. So the whole renal dose dopamine thing, like basically 0 to 3 mics per kilo per minute, gives you a little bit of increased contractility, but it increases your blood pressure. And then when you get above 5 of dopamine, it's blood pressure only. It's pure alpha. That's what we mean by alpha. Like beta's index stuff and blood pressure is alpha. No, what does it do to your cardiac output?
Drive it up.
What does it do to your blood pressure?
Decrease.
That's key. This guy, when they called me last night, was dry and his index was 3 His blood pressure was low, and he was on milrinone and 14 and Levophed. So what does he need? Milrinone turned off in volume, right? What's Levo do to your cardiac output?
Increase.
No.
Oh, even.
Basically, it doesn't do anything. Just it's. I mean, it's a little bit synergistic milrinone, but you got to think about Levophed. What's it do to your blood pressure?
Increase.
But Dr.
It's
Bates, on your
mainly this.
order, that Levophed is also for cardiac index.
Well, when you use it with milrinone, they are synergistic. That's why I always use milrinone and Levophed. But if you just add Levophed, it ain't gonna change your index much. What about neosynephrine? Was it your cardiac index? No. Doesn't do anything. How about your blood pressure? Vasopressin. What does it do to your cardiac index? What does it do to your blood pressure? So we use this when somebody's got just a really low cardiac index and a really low blood pressure and they're adequately tanked, right? Because we got to increase their blood pressure and increase their cardiac index. But remember, the cardiac index is low, you got to fix this first. This is always first. And then once this is done, then you get down to here, then you start all this stuff. That's for cardiac index. You know what I'm saying? That's why everybody's different. I rarely use dopamine. The only time I use dopamine is if like a couple days post-op, they're not quite pissing, they need a little bit of cardiac index bump. Because this makes you go into AFib. That's why I don't use it. I mean, you do. Maybe, I mean, but it's not wrong to use it. It depends where you train. Like that's the thing about this stuff. There's multiple ways to skin a cat. It's kind of how we were trained, wherever we were trained. You know what I mean? Like I use milrinone and Levophed almost exclusively, and if these aren't working, I need something extra. I add epi. That's where some guys just use epi. They don't use. You know what I mean? It just depends. So we did that. So when you use milrinone, if they've got good tank, good blood pressure, and they got high PA pressures, low EF, because the beauty of milrinone is it offloads your right heart too. So if somebody's got really high PA pressures, this is the drug of choice for them. Levophed is synergistic with milrinone, but that's mainly just for blood pressure. And again, blood pressure is kind of you always treat blood pressure with preload. Like the same sort of thing. Volume's always the first answer if they're CP. Drugs are never the first answer. You got to be sure they're adequately tanked, and then you start thinking about which one of these do I need. Neo rarely used, pure alpha. If somebody's like septic shock or one of those kind of people, and they're on like epi, levo, and they're still, then I'll use vaso and you know what I mean? That is pure tone. Like somebody's septic, endocarditis, having trouble going off pump, that'd be like neo and vasopressin. Does all that make sense? Any questions about any of that?
We had a patient on Sunday. The lady did surgery on Saturday, and her cardiac index dropped to 1.9, but her blood pressure was 140.
Milrinone.
You order epi.
I would use milrinone. Somebody didn't tell me blood pressure was 140.
Okay. I was just.
In that situation, typically, if they got a high blood, if their blood pressure is high, that's milrinone is a perfect drug. Epi's wrong for that. That's going to increase your blood pressure. Milrinone is the exact drug for that. They got a high blood pressure, low index, they got adequate tank.
Yeah.
Always. That means somebody didn't tell me what the blood pressure was. But this, I mean, that's pretty much how I do everything.
For the valve, so you want higher CVT and PAD, right?
What now?
For valve patient.
So, getting into specifics. So, the patients you have to be extremely cognizant of about tank is severe AS patients. Because what they get LVH. What that means is your ventricle's thick, right? So the problem with that is people get heart surgery, they get a pump run and all that, their heart gets stiff. So that's why that's why that was the volume right after surgery. Now, if you add in a muscle that's this thick, it's extra stiff. So somebody that gets an AVR, that's why Craig and I get so upset when we come up here and their pressure's been 90 all night, they've been peeing 25 to 30 all night, and the next morning they're basically they're in shock. Their LFTs will be through the roof, their creatinine's gonna that's a patient literally will be in shock the next day. I've seen people die from that. If you start turning up the levo and all that, not call anybody or any of that, you will kill that patient. I mean it. Severe AS patients, you have got to be tank.
So maybe 15 to 18.
It just depends what it was pre-op. It depends on what it depends. Like that's what I'm saying. You have to know what their PA pressures were pre-op. Otherwise, you have no idea. You're shooting in the dark completely. You have no idea. Now, if somebody's not peeing, what's the first thing you gotta send? Urine sodium. So, what's the urine sodium tell you? What's the number? You tell me. Like if what's number we're looking at? If it's above 20, now if it's above 20, then they should have adequate tank theoretically. Below 20, they don't. So the answer is they need more volume. Like my point is, if blood pressure still soft, preloads looks pretty good, they're still not peeing out, just send a urine sodium and that gives us a gauge. Now, having said that, what can screw up your urine sodium? Lasix. And what's the half-life of Lasix? 6 hours. So you have to, if they've gotten Lasix within 6 hours, then you got, but the funny thing is sometimes it'll still be, like if they're really dry, it might still even be low even though they did get Lasix, because oftentimes they won't respond to the Lasix if they're that dry. So I mean, you can still send the urine sodium, but if it's high, I'd still, you know what I mean? If you think they're dry, volume's almost never the wrong answer until they're way over the Starling curve. And then what happens if they get over the Starling curve? Like if you give too much volume, what happens? Yeah, you get heart failure, fluid backs up in your lungs, all that stuff. And you can check what to check that, a BNP. That's why we send BNPs all the time. If that's high, that means they're in heart failure. That's why oftentimes you'll see us we'll send a BNP in the urine sodium, because some of these patients are kind of complicated. You're not really sure because their EF's like 25 pre-op, and you're just trying to. Do they need more volume? Do they need diurese? I mean, but in general, I tend to not diurese people for at least the first 24. For sure, not the first 24, and hit or miss on the first 48. But usually that third day is when they start mobilizing all that volume they got, and you need to help them get rid of that, or they'll distend their atrium and go into AFib.
Dr. Mueller likes to give
Poison.
Lasix.
Yeah, I think that's just wrong. I don't know why he does that. I mean.
But what are we supposed to do when we call up and they tell us 40 lenses?
You have to do what he says, and it's my job to tell him to stop doing that on my patients. Basically, you can't you know what I mean? He's on call. If he tells you an order, just do it and just let me know that's what happened. I mean, you can't not do what he tells you.
I know.
I mean,
I sent a hip panel on your pressure.
never, ever, ever, ever do that.
Beluga, I sent a hip panel this morning.
Why?
My platelets
Platelets are always low.
58. He said send a hit, no blood. So I sent it.
What I call that is stupid, not harmful. There's stupid, harmful, and stupid, not harmful.
I agree.
And stupid, not harmful is fine. I mean,
Just letting you know,
that's
it just
fine.
happened this
Yeah, I
morning,
know,
'cause
whatever.
we all
But-
know you
but my
don't
point is,
wanna
it doesn't
do it.
matter. Like, but I'm not gonna start
It's not,
gasping and all that
it's not
shit.
indicative of anything.
Whatever. But my point is, the stupid, harmful, stupid, not harmful. That's stupid, not harmful. All right, what else? Somebody's bleeding out of the chest tubes. You guys immediately do three things. Send coags, including a what? Yes, including a fibrinogen. Turn the PEEP to 8. Why do I turn the PEEP to 8? Just increase your intrathoracic pressure to help stop a little venous crap, right? And what's the third thing?
Keep them warm.
Bear hugger, exactly. Somebody's bleeding, that should automatic. Send coags, turn the PEEP to 8, and put a bear hugger on. Automatic. Knee jerk, knee jerk.
And use
Okay.
the blood warmer.
Yes, and if you give them products, 100%. Do we have one up here?
Yes.
And they're running.
Okay. So this guy's on a balloon pump. So what the balloon pump does is it decreases afterload, right? So it lets the heart eject easier. And it also augments coronary flow and diastole. So the balloon inflates during diastole, so it forces blood down the coronaries. So you increase coronary flow and decrease afterload. That's the theory behind the balloon pump. The other thing is with balloon pump, you got to be sure that that thing's in the right spot. Because if it's low, I've seen people kill kidneys and livers if it's too low. Because you're literally occluding blood flow to the kidneys and the livers. The other thing is always be sure we got a pulse in the foot. You guys, I'm sure, I've never had an issue. You guys always do that. Always be sure there's a pulse distal. What else do you guys want to know? Now, just any questions, fire away. No stupid question. Any topic that you've just been wondering about.
Any topic, I've got one. So what is your protocol for patient that has had, a lung patient that has had their chest tube clamped and they start having respiratory issues? Do you want us to get?
Just unclamp it.
Just unclamp it?
Always.
Okay. Unclamp it right away, then just get a chest x-ray or?
Yes, both.
Okay, okay.
Just
Put it to
air on the side,
suction?
but when you unclamp it,
Yeah.
I want you to see if it bubbles.
Well, okay.
'Cause if it doesn't bubble, then that ain't it.
That's the problem.
You know what I'm saying? That obviously ain't it.
Okay.
But always err on the side of that. I mean, because what if they're actually having a tension pneumothorax? You call for a chest X-ray, you don't unclamp it, and they freaking coat. You know what I'm saying? Like, err on the side of unclamp. But I want you to look when you unclamp it. Like, that's the key. Look and see when you unclamp it if it bubbles. If it doesn't bubble, that ain't the problem.
Okay. Do we
I
ever
mean,
put it
you
on?
feel
I'm
better.
sorry.
I mean, you'll
And you can put it on suction.
Yeah,
Sure,
I was
well, yeah,
like,
that's
yeah.
never the wrong thing to do.
Okay.
Somebody's like, that's always err on the side of conservative. Just look, this is what I did. This I thought something was didn't bubble, but still in risk for it. They probably need Lasix. You know what I mean? There's something else going on, but that's never the wrong thing to do.
Okay.
Like if you have a logical reason why you're doing something, that's perfect. You know what I mean? Because I want you thinking. It's good.
The
Anything
only
else?
thing I ask for, Dr. Bates, is consistency. And I know it's hard because we have so many.
Well, it's hard because there's different guys. Everybody does it different. Like I said, there's different ways to skin a cat. Everybody does a little bit different. There's multiple ways to get to the right way.
But if we can get somehow on the same page
Standardized,
when it comes to AKI, or even just to preventive.
Meaning kidneys?
Yes.
If we're giving blood, the hematocrit is less than 25. And then it's in the a protocol already,
Well-
but we still need to call
Well,
the
that's
surgeon,
kind of
right?
yeah. Well, so that's kind of a
I don't think
Yeah.
we should have that in our.
Yeah, we should just remove it in there, so
Yeah.
it doesn't, because some, they are almost able to give blood, they said, no, you clarify.
Man, we
with the
should take that
surgeon
out there because
first."
that's
We should.
that's a real subtle thing when to give blood or not. Like when I give blood, if somebody needs volume, their crit's 22. And I give a bunch of albumin, what's going to happen? The crit's going to be 20. They're going to need blood. So I just give them blood. But if their crit's 21 or 22 and they're stable and they're fine, then I'll probably just diurese them, try to get their crit. You know what I mean? That's why it's
I think we should just.
that's a case to case thing. It's really not. You really can't knee jerk blood products.
Yeah, because Dr. Philippo and Dr. Mueller, they want to give blood only if less than 7. So it doesn't matter.
But see,
what
to
you
me, it depends. Like, if their crit's 21 or 22, like I said, and they need volume, if I give a bunch of albumin, their crit's going to be 18, we're give them, I just shouldn't just give them blood because they're going to need it anyway. And that's what they need. You see what I'm saying? But I mean, it's not wrong to do it the other way. There's
Yeah,
all
because
kinds
I
of,
call him,
there's
I have
papers
like
to
200
justify
chest
both.
blood, and then why
I
you
know.
don't want me to give blood, and they just want me to give albumin. I said,
No,
because
if somebody's bleeding and their crit's 22, they just need
That's- Call again.
Put it this way, if it's my patient, you can verbal that. If it's my patient, you can verbal that to me and tell me about it in the morning. If you know it's the right.
Call again.
Seriously.
Yes, but, yeah.
That's all.
But just tell me in the morning, hey, listen, I gave blood. I'm like, fine. What, you know what I mean? Fine.
Yeah.
Don't do it on your own. Make sure y'all aren't ordering stuff, like big stuff.
Yeah, that's the other thing. Like Craig said the other night, somebody was having belly pain. Somebody ordered a KUB, but then didn't tell us about it and put it under my name. The issue with that stuff is, it's not wrong that you ordered the KUB, but you got to call somebody. Like prime example, we had a patient, because if we don't know about it, then it puts you guys on the hook. You said, like prime example, we had a patient, this has been years ago, Lynn, you might remember this, years ago down in the old ICU or Lou might too. There was a patient that the nurse sent a UA and a urine culture without telling us, and we didn't see the UA, and the patient died of urosepsis within 24 hours. All we need to do is add Cipro. You see what I'm saying? Like, but no one told it. My point is, if you want to do something, fine, but you got just say, hey, listen, belly pain. But if for example, belly pain, KUB's right, but then belly pain after pump runs, you got to send amylase and lipase, LFTs. I mean, it's not just KUB, because that's going to show you non-specific small gas. You mean that's going to not show you nothing? I mean, it might, but usually it's just they got a small ileus because they're on a bunch of pain pills, but you got to send amylase and lipase, LFTs, lactate. You know what I'm saying? Like, that's why it's important that we know, because say he would have embolized something to his SMA or something with belly pain, and now it's 12 hours later before we get back in here and you tell us that he can be so far behind the 8 ball. You know what I'm saying? Like, that's why it's important to
Is
communicate.
it okay to ask the intensivist?
Yes, it's never wrong either.
Yeah.
Yes,
And then
that's
we
why
do
they're here.
that,
I
yeah.
consult the intensivists on every patient.
Yeah, but that's only 24 hours until they're stepped down. They don't
Yeah, that's fine. But remember, you can always reconsult them always. Like they're already on the case, like, and that's your first line. I mean, you should call us, sure, but if somebody you're really worried about, man, go grab and say, come look at this guy. And Giesel and them are cool with that. Like they're very cool with that, and they do a good job. They do a good job. So.
And then we have the issue with the residents ordering.
Yeah. So I don't know how to fix this. And this is we need.
Every 3 weeks I go in there and I
There,
give them
somebody ordered. One of the residents ordered lisinopril 40 milligrams on a post-op heart, which is insane.
recently,
Yes,
last
like
time
the other
we did,
day.
'cause we have new people that
Residents are not to be writing orders on heart patients, period. They are more than welcome to follow them and learn, but they are not to be writing orders, period. So I mean, I don't know if we need to put a sign out that you can just, and if a resident tries to write an order, you just say, Dr. Bates said no, and you can have them call me, fuck.
And again, is who's here.
Yeah.
There are nurses
They
that
are
are,
both
you know,
people
we
that-
have people that are floating, they wouldn't know. I mean, I'm.
See, that's the
sure.
problem. See, I don't know how to
But
fix
it's on
that.
the float sheet. If they're reading the float sheet, it says don't let anyone put any orders in. If you're reading the float sheet, then you shouldn't be letting people do that.
And then he was gonna take him to the cath lab. The
Yeah,
cath lab
well,
was
that's
gonna take him.
yeah, that's just
To do what?
that's crazy. First of all, the other thing is you should never, ever send troponins immediately post-op. You know why? Because they're going to be elevated. You know why? Because we cut on the heart. So that, okay, that's a good question. So if we're worried about a graft going down, and the thing that's going to tell you more than anything is a change in EKG, a change in rhythm, a change in cardiac index. So if I'm worried about a graft going, like in that situation, what I would have done is get an EKG. If that's normal, I got an stat
It
echo.
was normal.
Stat echo.
It was normal.
If you don't have a regional wall motion abnormality, there ain't nothing wrong with the graft. If they had a regional wall motion abnormality, you got to go to the cath lab.
It was normal.
Right. But
Yes, yeah.
the answer is not cath lab. That's exactly the wrong thing to do. Like that should be, like the patient should force your hand to go to the cath lab because it's so obvious there's a freaking problem that you have to go to the cath lab.
So Craig told us that if we do send a troponin, we won't.
You should never ever send your phone.
100 above.
Yeah, above 100. Yeah. So. If you do
It's
send
okay,
one, and there's no paper support, this is what they taught us at Harvard. They like, look, if it's above 100, then it could be an issue. But again, that first number still, it needs to see what the next one is. Because if it's 100, then the next one's 50. Who's code?
It's a code from
It's
Florida.
a-
Oh,
They have a code for
but you see what I'm saying? Like if it's above 100, but the next one's 70, it's probably off from the OR. But if the first one's 100, then it goes up to 150. It's probably a problem. But you should have EKG changes. You should, there should be something else.
And this is if we're worried that the graph is occluded.
Yes, like if all of a sudden their pressure drops, their index drops, their heart rate starts getting funny, they just don't look good. Like, and you guys will learn. Like, Len's caught a few issues like this. Just been up here with me. He's like, sometimes you just kind of get a sixth sense, man. Something ain't right. They don't look right. Like, I mean, and if you have that feeling, I mean, seriously, that's a lot of things I do is I go by gut. Like, for example, like this guy we did, his lateral. I was able to do 3 out of the 4 grafts. His OM was millimeter and very heavily calcified. And the problem is if you open that and you can't put a graft on it, you got to ligate it. And then they're going to die. So my gut in there was like, don't touch it. So I didn't touch. You know what I mean? Like sometimes you just got to use your gut and your judgment and just from years of getting burnt doing stupid shit. Honestly. Any other questions? What time is it? Any other questions? Anything?
Y'all good?
So the other thing we need to do, next time we need to do, so Jody's getting the order sets. So when she gets them to you guys, I want you to read them.
I'll do that when we, well, yeah.
Yeah, so read them and then if we have, the next time we'll answer any questions about any of that. And then also we need to do a mock Hemodynamics. We need to do a mock chest cracking drill.
We're getting rid of like 50 meds on the orders. Like for real.
Yeah, they're hardcore consolidating. Hardcore consolidating.
Who is it?